And in this video, as the trial of the nurse Lucy Letby nears its conclusion, the jury now hear from the judge and his final summing up of the case against Lucy Letby. The judge, Mr. Justice James Goss, is now beginning his summing up. He says the prosecution case is there was deliberate harm at the Countess of Chester Hospital neonatal unit, sometimes repeated attempts on the same infants, and some of those infants died. He says after child O and child P died and child Q collapsed on successive days in June 2016, Lucy Letby was confined to clerical duties. He reminds the jury of the background to the offences alleged on the indictment. He says the Countess of Chester Hospital is and was busy. He says the jury are now familiar with the tertiary system of hospitals, with the Countess a level 2 unit, routinely providing care to babies of 27 plus weeks gestation. The jury have been provided with a guide and walkthrough recordings of the unit. One room, room 1, the ICU room, had 4 incubators and 2 computers, plus other pieces of equipment. Room 2 was the HDU, rooms 3 and 4 were special care babies rooms. He tells the court the last evidence heard was from Lorenzo Mansuti, an experienced plumber at the Countess of Chester Hospital. The Women's and Children's building was built in the 1960s and there were issues with the plumbing. There was an incident between 2015 and 2016 where the hand basin backed up with foul water. There was also another incident where room 4's floor flooded after a backup sink overflowed. None of the incidents reported happened on the days when the alleged offences took place. In regard to staffing levels, consultant Dr. John Gibbs had said in evidence it would have been better if there were more consultants, but refused to say the staffing level at the time compromised the care of neonatal infants. He says every year up to 2015, the number of deaths at the neonatal unit was within the number to be expected and less than the national average. Between 2015 and 2016, the number of deaths increased significantly, including the number of unusual events. The defence said this was a consequence of higher admissions and a higher number of infants with more complex needs. In evidence, Letby was asked about her relationship with other staff. She said she had no problem or issue with any of the doctors and had a normal working relationship with them at the time, except for one female doctor she did not get on that well with. She said she loved one male doctor as a friend, but there was no loving relationship between the two of them. She later said 4 doctors had conspired against her falsely: Dr. Stephen Breary, Dr. Ravi Jairam, Dr. John Gibbs and one other. Moving on to the care of the babies, the judge says established BAPM gold standard guidelines had 1 designated nurse to 1 ICU baby, 1 nurse to 2 HDU babies, and 1 nurse to 4 special care babies. He says nursing notes would be written retrospectively on computers. They had an accurate electronic timing of the start and completion of the note. He says nurses were asked about staffing levels. The court had heard from one nurse, quote, "Sometimes there were more babies on the unit than there were meant to be." 2015 to 2016 was a busy period, with more babies with higher acuity. Staff were giving up breaks to provide care. Another nurse said it was always quite busy. Dr. Breary accepted nursing levels were lower than the gold standard guidelines. He added their levels were similar to other neonatal units, and staffing levels were better than those around Cheshire. The court heard the other units did not have the mortality levels. The judge says the jury should consider if suboptimal care was a factor in the collapses of the babies. He says in a few cases it is accepted there was suboptimal care. He said Letby accepted herself that suboptimal care played little or no part in most of the babies' cases. He says defence barrister Benjamin Myers Casey repeatedly suggested that doctors had gone out of their way to damage the defendant by blaming her for suboptimal failures in care. He says she did nothing to harm any baby. The judge says it's up to the jury to find out who is telling the truth and who is reliable. The judge says in 2 cases, 2 babies received insulin when it was wholly inappropriate to do so. The prosecution say there is no doubt it was added intentionally. The prosecution say the chances of more than one person acting in that way administering insulin is not realistic. He adds, the defence invite the jury to question the samples and the lack of harm caused to the infants if they had been poisoned by insulin. He says the prosecution say the intention was endangering the lives of the 2 babies. The judge says the prosecution referred to a list of reoccurring factors for babies in this case. He says for the defence, they say Letby was a committed, hard-working nurse, and if there was someone intent on harming children, it was not her. The judge now gives the background to Letby, starting as a nurse at the Countess of Chester Hospital in 2012 as a Band 5 nurse. The court has heard Letby always strive to go on every course she could. In March-April 2015, Letby had completed a 6-month course including a placement at Liverpool Women's Hospital. She qualified in the speciality of caring for intensive care babies. She was the only Band 5 nurse, along with Bernadette Butterworth, to have that qualification. The judge says Letby has no previous convictions. He says it is entirely for the jury to attach the weight of the defendant's previous character. Letby had said she had cared for hundreds of babies and that hurting a baby was completely against everything a nurse is. Colleague Christopher Booth confirmed she was conscientious, hard-working and willing to help. Another colleague said Letby would remain friends with the parents of babies on Facebook. Arian Powell said Letby was an exceptionally good nurse. Letby had a passion for working in the intensive care side and staff knew she enjoyed that side of care. The judge says Letby's health was good and she did not take time off work in 2015 or 2016. She was flexible, living at Ash House, accommodation at the Countess, then at a flat between 2014 to 2015, then back to Ash House until April 6, 2016, when she moved into her home on Westbourne Road in Chester. Letby was often asked to do more than a required number of shifts per month. She was devastated when taken off clinical duties in 2016. She had prided herself on being very competent. Letby registered a grievance in September 2016. It was at that time she learned she was being blamed for the deaths and that was sickening, and her mental health deteriorated. She was arrested at her home in July 2018. She was interviewed, then moved to Hereford to be with her parents. A search was conducted of her Chester home. The judge refers to expert witnesses who have given evidence in the case. He says the jury would expect to hear evidence from experts with relevant expertise. Their role is to be a witness, not an advocate. He says the defence have criticised that evidence and will come to that when going through the relevant cases. He says the jury are entitled to consider their opinions when coming to the conclusions on the case. It is up to them to consider some or all of their evidence. He says their evidence is part of the case and the jury should not consider it in isolation. It should be considered in the context of expert, clinical and relevant circumstantial evidence. The experts did exclude some reasons for collapses based on their knowledge and expertise. The judge now refers to the case of Child A, the twin of Child B. He recalls the events of their birth and the collapse. Child A's cause of death was unascertained. The prosecution case is Child A did not die of any natural cause, but instead had air deliberately injected intravenously with the intention to kill. The defence say Letby did nothing to harm Child A and raised issues with the long line. The judge details what neonatal unit staff were accorded and recalled doing for Child A before the collapse. He says there were issues citing a cannula, which can happen. A long line was later inserted by Registrar Dr. David Harkness. Nurse Melanie Taylor came on duty. Child A was stable and satisfactory, and the nurse had no concerns. She ended her shift at 8 p.m. and handed over to the defendant, who came in at 7:27 p.m. She confirmed a 10% dextrose bag had been prescribed to be given via the long line. All 3 babies that night in room 1 required long lines: child A, child B and 1 other. Dr. Harkness was unsure if the long line was in the perfect position. He believed it was imperfect but good enough to be used. Dr. Evans said the position was not a problem and there was no evidence of the end of the line puncturing the heart lining. He said if there was, it would show up on post-mortem examination. Dr. Sandy Bowen said it was not in an optimal position but safe to use. Melanie Taylor said she was sitting at the computer in room 1 when child A started to deteriorate. The alarm sounded and Melanie Taylor went over thinking the baby was going to recover. She said Letby was administering Neopuff. She says it was a bit of a blur. Letby said she was not initially intending to work that night shift but was happy to help after being asked to work. There was a lot going on, and she said Melanie Taylor, being the sterile nurse, was administering fluids. Child A's hands and feet were white at the time of the desaturation, centrally pale and poor perfusion. An emergency crash call was put out. Dr. Rachel Lambie had said child A looked like child B, pale and blotchy all over. The defence said her original police statement referred to child A being pale with white hands. The defence draw your attention to the difference, the judge says. Dr. Harkness had given a description of the blotchy rash, saying it was only seen again by him in the case of child E. The defence criticised him for not including the description in medical notes at the time or in notes to the coroner. Dr. Ravi Jairam had said it was highly unusual in the way that child A was deteriorating and his heart rate fell, even after intubation. At the time, he noted child A's pale skin. His explanation for not including the pink patches skin discoloration to the coroner but mentioning it to the police later was he had not considered it clinically relevant at the time. He said it was a matter of regret he had not mentioned it. He said he could not explain how child A collapsed. He said he read a document in a medical paper about skin discoloration in a case of air embolus. He said he had not been influenced by that paper when it came to that explanation. The judge is now referring to Lucy Letby's police interview, where she recalled red, purple blotchy markings on child A, which she thought were signs of an infection. She believed there was an issue with the long line and Melanie Taylor had connected the fluids to child A. Child A's death was not expected or anticipated. She said she thought the bag of fluid was, quote, not what they thought it was, but they had checked it afterwards. She said she did not keep in touch with the parents and did not recall what she did with the handover notes. She said she did not know much about air embolisms and all the staff were meticulous about precautionary checks to prevent that happening. She denied pushing air through the line. She could not recall using social media to search for the mother of child A, and when asked to explain searches for the mother on Facebook, she said she could not do so. Letby said the fluid bag should be contained and put in the sluice room for checking. She said staffing levels contributed to the death of child A, citing difficulties with the long line and child A's lack of fluids for several hours. She said if air embolus was the cause, Melanie Taylor was responsible. She disagreed with the description of skin discoloration given by a nursing colleague and Dr. Harkness. She said searching for the parents was a common pattern of behaviour for her. The judge says Mr. Myers repeatedly expressed his opinions on the merits of the expert evidence, questioning and challenging them. He says that is his right, but it's up to the jury to determine the reliability of the expert evidence. The judge refers to Professor Owen Arthur's evidence, who considered each case on its own merits. Professor Arthur's was provided with radiograph images of child A. He noted the umbilical catheter was slightly in the wrong place and there was a line of gas in front of the spine on one of the images, which was an unusual finding. He said it was so unusual he reviewed other cases at Great Ormond Street Hospital to compare for a similar image. He said such gas would normally only be seen in heavy impacts such as road traffic incidents. This could obviously be discounted. The other usual cause would be overwhelming infections in organs of the body such as sepsis, but child A did not have any such identifiers. He said he had not seen this much gas in any baby other than in the case of child D. He said it was consistent with air administered to him, but not diagnostic of it. In cross-examination, he said he found no unexplained cases and accepted this was an observational study, not a controlled one. The judge says for obvious reasons the latter could not be carried out. Professor Arthurs said radiographic evidence of air embolus was rare, and in suspected cases seeing anything on the radiograph was also rare. He said the absence of it on the radiograph did not rule that cause out. He said one of the reasons is the imaging of the event is not important. The main priority is to save the life. An X-ray taken an hour later wouldn't show anything. The judge refers to the expert witness Dr. Andreas Marnarides' evidence. His expertise, the court is told, is on the pathology of conditions on those who had died. He said there was no evidence of infection or any other abnormalities. He could see from his study empty structures of fat or air in child A. After testing, he ruled out the former. He said he could see evidence of air in the brain when the baby was alive. The findings could not be taken as absolute proof of air embolus. He said there was no evidence of any natural cause of death or any of natural disease. He took the view that child A's death was of air embolus via injection. The judge refers to Dr. Evans and his role in providing background evidence for child A. He said, on the whole, babies don't suddenly collapse. He said child A was the 5th case he looked at, and the cause of the collapse was unusual. He said as he looked at further cases, he noticed a pattern as he received more evidence. He said Dr. Evans' evidence came for criticism by the defence. He had not been in practice since 2009, and the defence said he had constructed theories and acted as an investigator and was biased, putting himself forward at the outset. The judge says the prosecution point to a large number of incidents for review with no apparent reasons for an event or death. They point to Dr. Evans' long experience in neonatology and provided clear evidence in child F and child L that identified 2 babies on the unit were being poisoned. The prosecution say Dr. Evans was not handed other potentially incriminating evidence such as shift patterns for staff. Dr. Evans said child A was stable and as well as could be expected before the collapse. Repeated attempts to insert a UVC or long line may have caused upset to child A, but would not have caused the collapse, he said. The lack of fluids would not make a material difference. Bright pink skin discoloration would be unusual in a baby's collapse, but skin discoloration is not diagnostic of an air embolus alone, Dr. Evans said. He denied he had been influenced in reaching his conclusion by a 1989 medical paper. He said in child A's case there had been colour change, sudden and unexpected collapse, air in various parts of the body, and no explanation for death. He said it was probably an air embolus intravenously. The judge refers to Dr. Sandy Bowen and her evidence for child A. He says the defence accused her of lacking independence and enthusiastically supported Dr. Evans' evidence. She repeatedly denied these assertions and said her views were her own. The judge says it's up to the jury to assess the validity of the defence's assertions. Dr. Bowen said neither the UVC or long line contributed to child A's collapse. She said child A was so well that there was consideration to giving him feeds, and babies doing well do not develop pink fluctuating rashes that come and go. She said excluding other possibilities, air embolus was the only plausible explanation, and believed air getting in accidentally was extremely unlikely. Studies on air emboli should be treated with caution as they are on adults or animals, she said. In cross-examination, she said she did not know of any genetic condition that would cause a collapse and death within 24 hours of birth. The judge describes Professor Sally Kinsey's evidence, in which she had concluded from the descriptions by doctors and nurses of skin discoloration that child A had had an air embolus. The court had been told of how an air embolus affects the body. She confirmed she had not seen one in her experience, but the descriptions provided were pretty stark.